So we are live.
Thank you. Good evening to all. My name is Sanjay Prakash. I'm the Regional Business Manager with Pfizer. At the outset, it's my privilege to welcome today's esteemed faculty and also to today's healthcare professionals who have joined to this virtual meeting on this wonderful evening to discuss and to understand on a very important topic, ALK rearranged non-small cell lung cancer. It's my privilege to welcome today's esteemed faculty led by our program director, Dr. S.V.S.S. Prasad sir, and the program would be moderated by Dr. Vamshi Krishna sir, and we are joined by expert panel who would give their opinion on this very important topic, along with Dr. S.V.S.S. Prasad sir and is Dr. Poonam Patil ma'am and Dr. Rakesh Reddy sir. I welcome the esteemed faculty members to this very important meeting. It's my privilege to introduce Dr. S.V.S.S. Prasad sir to the august faculty members and also to the virtual healthcare professionals who have joined to this meeting. Sir is an astute clinician with over 25 years of experience in the specialty and with over 40 years of overall experience. Sir has more than 15 scientific papers in national and international journals of repute, and he has been a part of many multinational clinical research projects as a principal investigator and co-investigator side with a successful FDA audit in 2009. Sir, welcome to the talk. And today's moderation, as I said, would be moderated by Dr. Vamshi Krishna sir, and would be the expert panel opinion would be given by Dr. Poonam Patil ma'am and Dr. S.V.S.S. Prasad sir and Dr. Rakesh Reddy sir. I'm sure you'll all agree with me with the fact that the treatment of the metastatic non-small cell lung cancer has undergone a paradigm shift over the last decade or so, with better molecular characterization of the disease, which has led to a rapid improvement of personalized medicine and prompt delivery of targeted therapies to the patients with NSCLC. The discovery of EML4 ALK mutated fusion gene in the limited subset of patients with NSCLC and the subsequent clinical development of crizotinib in 2011 has been an impressive milestone in the treatment of ALK mutated non-small cell lung cancer. However, over the period of last 10 years or so, the subsequent generation of treatments, the subsequent generation of ALK inhibitors has led to the development of various other molecules as well. Today, to discuss more and to say how to raise the bar in treating the ALK mutated non-small cell lung cancer, we have the esteemed faculty members moderated by Dr. Vamshi Krishna sir, who is the director and head of medical and hemato-oncology at the AIG Hospital, Hyderabad, Dr. Poonam Patil ma'am, who is the senior consultant medical oncologist at Manipal Comprehensive Cancer Center, Bengaluru, Dr. S.V.S.S. Prasad sir, who is a senior consultant medical oncologist at Apollo Cancer Center, Hyderabad, and Dr. Rakesh Reddy Boya sir, who is a senior consultant medical oncologist at Apollo Hospital, Visakhapatnam. With this, I welcome Dr. Vamshi Krishna sir. I welcome Dr. S.V.S.S. Prasad sir to give his introductory talk on this very important topic. Before I hand over, I apologize for the mistake that I've made on the heading. Sorry. Over to you, sir.
Yeah. Good evening, everyone. Thanks, Mr. Sanjay Prakash. All of us are familiar with ALK positive lung CS and its treatment with crizotinib. Hello? Yeah? Yeah. We are all familiar with crizotinib, ceritinib, alectinib, and so on. And also some of us have had experience with lorlatinib, which was available earlier on compassionate grounds and now is in the market. And I am sure Dr. Vamshi will take us through all these developments and the importance of the various ALK inhibitors in their respective places. And without wasting much time, I would invite Dr. Vamshi to conduct the further proceedings. Dr. Vamshi, please.
Thank you, Dr. Prasad, and thanks for that lovely introduction. It's always a pleasure to talk about things that change and things that change in a good way. And ALK positive NSCLC is certainly one of the paradigm changing things in lung cancer. 10 to 12 years back, we hardly had departments which would look at lung cancer. And over the last 10 years, with the advent of the entire precision oncology, we now know that oncogene-driven cancers have much better prognosis and in several cases have much longer outcomes than traditional lung cancers. So today I will be talking of management of first-line ALK rearranged NSCLC. Next slide, please. So in the course of the next 1 hour or so, what I will discuss would be a general overview, then looking for CNS disease in ALK positive NSCLC, managing the CNS disease, looking at treatment strategies. I would spend a little bit of time on lorlatinib, how it works and the design of the trial. And then of course the CROWN study with its study results and all, and how we manage the A's. Now, I think it's kind of a long time that we have been talking of ALK positive NSCLC. So I'll not go back to crizotinib trials, crizotinib trials and alectinib trials. We are all aware of those studies. What we will try and do is to put all that knowledge in context with lorlatinib and see where the management of ALK positive NSCLC is there today in 2022. Next slide. So as we all know, next slide, please. Lung cancer is one of the most rising cancers among all of them. If you look at lung cancer incidence in India, according to Globocan, this is the 4th most common cancer diagnosed in India. Now, with distant metastasis, it is in 44% of males. In females, it accounts for around 47% of patients. If you look in terms of absolute numbers, the estimated number of new cases in 2020 was 72,000, which is anticipated to rise to more than 120,000 in 2040. These are big numbers. Next slide, please. Now, again, when you look at the mortality, the figures are still rather grim. Estimated number of deaths are close to 66,000, which will rise up to 110,000 among all patients. Now, it's interesting to note that the lung cancer mortality in India is considered to be highest for one of the highest for lung cancers. Now, overall, when you look at it, it is still breast, it is still cervix, but lung is becoming significantly higher. And this number will only possibly grow up as we manage to get treatments for the other types of cancers. So overall, lung cancer is one of the most significant cancers that are there in India, and it is a growing problem as well. Next slide, please. Now, in this lung cancer, as I discussed earlier, the entire paradigm of treatment has changed with the revelation that you have oncogene drivers, and these mutations have their own drugs. Now, over days, this number keeps changing. 6-7 years back, we would say EGFR is only possibly around 30%. Then you had ALK being discovered. Then you got the new ones. So presently, if you see in the Western data, you have EGFR around 23%, ALK around 7.9%, and then BRAF, B2, all these accounting for around 2 to 3%. Then you have newer things like MET, MEK1, NRAS, PIK3, all of them less than 1%. Throw in the NTRAX, throw in the RET, which we have a target now, and the number just keeps on increasing. Now, in India, this number is actually higher. So if you look at EGFR, it's as high as 30 to 40%. If you look at ALK, it's as high as 5 to 12% in different series across various institutions in India. Next slide. So when I'm talking of ALK rearrangement, what exactly are we talking about? Now remember, ALK in around 5 to 10% of patients. Typically, we see this in patients who have adenocarcinoma, usually non-smokers or light former smokers, tends to occur in younger patients. So when you're having any of this criteria, younger patients who are non-smokers with adenocarcinoma or even an adenosquamous, definitely look for a driver mutation, and ALK is one of them. Now, the mutations that we see include the EML4 and the ALK and the EGFR. Now, interestingly, both of these are usually mutually exclusive. 5%, yes, we do see these also coexisting. Now, these cases are being increasingly picked up when we do a NGS. So that brings me to the next point. How do you detect these mutations? Over time, several sensitive and specific diagnostic techniques have become available. Initially, this started with the DF53, D5F3 IHC staining, which would look on IHC and find the ALK positivity. After this came the FISH testing, where we knew that FISH testing is possibly more accurate in picking up these fusions. And now, over time, we know that the RNA fusions on NGS would also be picked up. And therefore, an NGS with RNA fusion is possibly being now a standard of care. Now, among the variants, you have different partners. Essentially, a part of EML4 and a part of ALK get fused together to produce this kind, the ALK EML4 fusions. So you have different types depending on where the fusion has occurred. These are various numbers. Now, till a few years back, we had the luxury of just ignoring these numbers and say EML4 ALK. That's no longer the case. We do need to look at the kind of fusion that we are dealing with, because that also tells us the response to individual drugs. Now, among these, you have different types of variants. You have type 1 variant, type 2 variant, and type 3 variant. Again, these variants help us because not all the variants are responsive to the inhibitor, the ALK inhibitors to the same degree. Beyond EML and ALK, you do have some rarer fusions like the Ki51B or the TGF, which also fuse with the ALK tyrosine kinase domain to give you a ALK positive NSCLC. Next slide, please. So what exactly is this ALK? Like I was saying, it's a gene fusion. So for example, if this is the EML4 gene and this is the ALK gene below, the tyrosine kinase domain of the ALK gets fused with other part of the EML4, and that fusion results in a fusion protein where the tyrosine kinase becomes constitutionally active. So that's what the ALK is all about. Now, you could have an inversion that occurs when a chromosome is broken and it is reversed and reinserted, or you have an inversion which causes a fusion of the ALK and the EML4 gene. Now, initially reported in 2007, but this is where all the ALK and EML4 have come. And like I said initially, where the fusion is occurring, with what partner it is occurring, both of these determine the responses to various drugs as well. Next slide. So if I could come to my panelists now, can I start with Dr. Poonam Patil, ma'am, please?
Yes, please.
So, ma'am, again, the same question, what is the incidence of ALK mutated NSCLC in your practice?
Approximately 3 to 4%.
3 to 4%. Okay, interesting. Dr. Prasad, sir? Dr. Prasad?
1 second. I'm muted. So 5 to 6% is what I see in my practice.
5 to 6%. Very good. Dr. Rakesh?
5 to 10%.
5 to 10. I think I'll agree. My practice is less than 5%. I'm a little unlucky when it comes to ALK, looks like. Could be just luck of the draw. But yes, around 5%. Now, it was interesting because initially I used to think the same. It is around 2 to 3 or 4%. But then we had data coming in from Indo-American in Hyderabad. We had data coming in from RGCI. We had data coming in from TMH. And there, you know, it went up to 7 to 10%, which is a bit of a surprise to me, but that's what the data is. Could it be because of testing platform? So, Dr. Rakesh, what is your testing platform? Is it IHC or are you doing an NGS now?
Yeah, so it depends upon the tissue that I'm playing with and the paying capacity of the patient and the amount of the time that I have and whether it is a smoker NSCLC or a non-smoker NSCLC. If it is a non-smoker NSCLC, I would always try to get an NGS done, especially if I have decent amount of tissue thing. Across the board, NGS has been the go-to test now. Especially if the lab gives a good RNA fusion report. That is what I'm specifically looking at. If I have very little tissue and condition where NGS is not feasible, then ALK by IHC is what I would go with. So NGS first or ALK with IHC as a second alternative.
Perfect. Dr. Poonam, do you agree with this? Are you going with this or are you still trying to do, there are labs which, there are centers which do an IHC within 2-3 days, a PCR EGFR within 4-5 days, and an NGS within 15 days. They combine everything to give you early reports. Is that your practice, or would you also do like
The
Rakesh?
practice has changed a little bit in the last few months or a year. Earlier, Pfizer used to give us coupons, and we used to do ALK by IHC for everyone and confirm it with fish if it was positive every time.
Okay.
But now definitely NGS is being done for all the patients. And if we have extra tissue, then I would go for IHC because I might get the results early.
All right, perfect. Dr. Prasad, sir, your thoughts on this?
We were earlier doing the IHC and fish method, ALK and all that as a panel, as a lung panel, which you also must be aware during your stay.
Yes.
Now we are slowly moving to the NGS side, especially as Rakesh said, not more with the tissue, more with the money, I would say, with the patient. And so, yes, at the moment, both are being done, NGS as well as the IHC bar fish.
Perfect. So I think this is a trend which a lot of us are seeing. In most meetings, when we go across and ask people, this is the answer that we are also getting, that, NGS seems to be the method of the future. NGS seems to be the standard which all of us are following. Now, the interesting question for me is, do we actually look at the ALK variants and then decide our treatment? Or are we just saying, okay, ALK and, hey, we are good to go? Rakesh?
No, for the first line treatment, not exactly. If it is ALK mutation is there, or ALK, if the ALK fusion is detected by NGS or ALK IHC is detected, ALK expression is detected by IHC, it is good enough for me to start a first line treatment. For second line treatments, yes, mutation does play a role, especially with the variants that we keep seeing as resistance mechanism.
Perfect. Dr. Poonam, ma'am, same for you. I think Poonam has just logged out. Dr. Prasad, sir, same for you. Would you look at what variant it is, or would you say,
I have to confess that I was not looking at the variants, especially with all the available ALK inhibitors so far, and also the NGS being not in my hands. Now that we are looking at NGS, yes, we do look at the translocations, especially in the second line, not in the first line, I would say.
Okay. So I think that seems to be the theme, that in the first line right now, though all of us are aware of the data that yes, there are some mutations more sensitive to a particular drug, but by and large, we are treating them one and the same. So excellent. Next slide, please. So what is the unmet need in ALK positive today? If you look at this, generally, ALK positive patients are younger and non-smokers. One of the most important challenges is the CNS metastasis. Now, CNS metastasis, we are well aware, occurs in more than 20 to 40% of untreated patients. And it also occurs in a bigger percentage of patients who are on ALK treatment. Now, the treatment challenge today includes things like ALK resistance mechanisms, the mutations, the CNS metastasis, a durable control of brain metastasis, and need for additional TKIs that would prevent the emergence of resistant subclones. So these are things that are important in ALK. But again and again, we read more and more of ALK, we treat more and more of ALK. The CNS is what really comes again and again. Next slide. And looking for this CNS disease is important. Now, again, the data says, or the guidelines say, that for like NCCN, for example, or ESMO, for example, all of them do recommend a cranial MRI with contrast or a CT with contrast. Now, ESMO recommends CNS imaging with MRI or a CT with iodinated, and screening is beneficial and preferable. Now, in clinical practice, it may not be feasible, is what a lot of people do say. So, next slide. Next slide. So, if I could ask just a quick question from my panel, Dr. Rakesh, is it really an issue for us? Because frankly, in India, we all jump and do a PET scan, which includes a CT scan of the brain. So, if it is negative, would you still do an MRI of the brain for ALK positive?
Definitely, yes. A contrast enhanced MRI, definitely, yes.
Perfect.
I think even more so.
Perfect. I think for EGFR and ALK, I think that's kind of a given nowadays. We do want to look for these mutation. Now, the way I look at it is, yes, I'm happy if my PET-CT doesn't pick up because I know they're going to be small. But even if small, it is important to know that they exist so that we can tailor our treatment accordingly. So I think that's something which most of us are doing. Yes, resource constraints are there, but I think MRIs are pretty much available in every corner of India nowadays. So the other thing is, when you do have ALK positive NSCLC with CNS disease, what you do? You can have systemic therapies, all the targeted therapies, and of course, you have local therapies. Now, as per general condition, now what we have learned over the last few years, if you have an actionable oncogenic driver, patient is asymptomatic, use CNS penetrant TKIs. I think that's the message, whether it's EGFR, whether it be ALK. If patient has CNS metastasis which are symptomatic or which are larger and multiple in number, involve a multidisciplinary team, have neurosurgeons, medical oncologists, radiation oncologists, and then take a combined decision of what you want to do. The aim here is to, of course, maintain long-term survival, obtain good local control, and then have a good QOL. I think this is where we would want to be when we talk of CNS metastasis for lung cancer patients. Next slide, please. So this is the international guideline recommendations when you have patients for first-line ALK positive. Now, if these ALK positive recommendations, ALK positive rearrangements are discovered prior to first-line therapy, again, I will take this guideline with a pinch of salt. In India, I think by now, most of us would wait for these results, or else most of us get the results within first cycle itself. You have options of alectinib, brigatinib, and lorlatinib, which are all category 1, by the way, and preferred, and ceritinib category 1. Poor crizotinib, which is one of our old friends, has now been pushed to only useful in certain circumstances. And SRS, of course, recommended only for limited. Again, this is something which by now even medical oncologists are aware that there are places you can do SRS and places you should not do. Next slide. So now the question comes, how would you like to sequence these patients, sequence all our options in patients with CNS disease at baseline? So what are our options? Number one, you would want to give an ALK TKI with a good intracranial activity and CNS disease control. So you have one algorithm where you say you directly go with your Lorla, which is the best in CNS, and later go with chemotherapy and local therapies. Secondly, you could go with a first or a second generation ALK TKIs, then go with lorlatinib, and then go with chemotherapy. Next slide. So there are several challenges in this. And before I go on to the other alternatives, let me get back to my panel. Dr. Poonam Patil, madam, what's your usual practice when you look at patients with asymptomatic CNS metastasis? Are you looking to give first line, or would you directly want something which is stronger intracranially?
I would directly, if cost is not a constraint, I would directly want to go with something which is good intracranially as well, because they have a high incidence of CNS metastasis, which could be apparent on MRI, or it could be even occult metastasis, and in no time they start developing CNS disease.
Rakesh, your thoughts on this? Would you say that, ceritinib, we did have data not as good as Lorla possibly, but reasonably good. And then alectinib came up with this data and said, look, CNS control is much better than ceritinib. And, now Lorla has much better.
Yeah. So the keyword here is asymptomatic brain metastasis. So if it is an asymptomatic brain metastasis, I am very happy reserving lorlatinib. I think alectinib has a decent enough intracranial penetration. The CNS responses are in the tune of 70%, which is pretty good. For an asymptomatic brain metastasis, yes, I would like to give alectinib first and then reserve lorlatinib. If cost is an issue, I'm equally happy putting the patient on ceritinib as well. For 45,000 with patient assistance program, I think it is a decent bargain. And then do the lorla or alectinib at time of progression. So I would reserve lorlatinib for those bulky brain metastasis and where it is symptomatic and you need to get a very rapid response in CNS and probably avoid a whole brain RT setting.
Okay, so Rakesh is not a friend to a radiation oncologist. He wants to even give in big bulky tumors. He wants to avoid whole brain RT. I'm just kidding. I would do the same. I mean, it's always good to, because we are talking of diseases where now we are looking at several years of survival.
Yeah.
And whole brain RT is associated with a distinct cognitive impairment over 2-3 years. So, that's something which is real and we have to be aware of it. Dr. Prasad, sir, your casting vote. We have one who says, let's just go with lorlatinib, the best intracranial. And Rakesh who says, no, I want to reserve it for my second line. Your thoughts?
Asymptomatic individual, I would prefer a CNS penetrant drug, either an alectinib or a lorlatinib. Either of them I would choose. Reserving lorlatinib as a second line, maybe it will be late, in my opinion. I would rather go with radiotherapy in case it still crosses the lorlatinib situation.
Okay. So again, Dr. Prasad has very diplomatically tried to stay on the fence on this. But again, I think what it all tells is you have to customize your approach to the patient. You cannot simply have a one-size-fits-all approach. And I think that's what most of us would do. Leaving aside the cost in those issues, which I think we should not really be discussing today again and again. Beyond that, if you look at the bulk of disease, that's one way to go about it. The other important thing which Dr. Prasad did make a point, you leave the first line. If you're on alectinib, for example, and the patient may progress to in such a way that you're not eligible for the second line drug at all. You need to be careful in monitoring. We have all seen that patient suddenly deteriorates and is just not fit enough for a second line. So you lose the chance of using lorlatinib. So that's one more thing which we need to consider when we are talking about it. And as always, it comes down to a discussion and patient's characteristics, tumor characteristics, and all these things put together. Next slide, please. So if I can summarize, this is something what we have, that in patients with an ALK positive NSCLC, the incidence of brain mets is 20 to 30%. We should test for these. All ALK positive TKIs have been evaluated, but the benefit or the CNS penetration is not seen for everyone. Among them, lorlatinib seems to be one which has been approved, and it has the potential to manage and prevent the emergence of CNS metastasis. But you have to understand the prognosticators, and we have to discuss with the patients all the options. And certainly, it's not a given that you should use only lorlatinib, though it is an attractive choice. You could, in certain cases, try a first line and then use lorlatinib, the second line as well. So next slide, please. So that really brings us to the star of today, or rather the main theme for today, that is the lorlatinib. So what exactly is lorlatinib? Lorlatinib is nothing but a selective, highly potent third generation ALK TKI. Now, when we say it's a third generation, it was essentially designed in such a way that it would have a better brain penetration. Crizotinib did not have much brain penetration, though, I remember the early days when I was preparing for this presentation, I went back to my old presentations of 2012-13 when you tried to look at crizotinib levels in CSF. We know by now that, lorlatinib is much better at brain penetration. Now, not only brain, in overall and intracranial activity, in previously untreated patients, lorlatinib has shown improved clinical outcomes. Now, the other important thing about lorlatinib is that it can suppress or delay on-target resistance. Now, the resistance to all TKIs is through these mutations which can occur and on-target mutations which can occur. And lorlatinib does have the capacity to suppress or delay these on-target resistances. Next slide. So when you look at, of course, the kind of the molecule, it's slightly different from crizotinib. Now, this drug was very rationally designed to address the metastatic part of it and the resistance part of it. Next slide. So then comes the rationale as to why at all should you try to come to the first line. That's how all our drugs go. The initial part, the initial studies, especially the phase 2, showed that lorlatinib has good intracranial activity in patients with CNS disease. So that obviously suggests that perhaps if you use it in first line, you may be preventing the emergence of brain metastasis and you may manage the brain metastasis as well. Now, this result was also shown in those patients who had failure to first and second generation ALK inhibitors. So again, in untreated patients, there were some case reports and initial studies that showed that lorlatinib may eliminate pre-existing subclones with mutations. So all this put together is really the rationale why lorlatinib should be established in the first line setting. And again, I'm just going over the things that all of us are aware of. Next slide. So that really comes to the phase 3 CROWN trial, the study design, the results, and the conclusion. Next slide. Now, the CROWN trial was a very interesting study. Now, they basically took a plunge here. Now, for those of us who remember our history, a crizotinib and a ceritinib were tested against chemotherapy. Ceritinib was never tested head-on against crizotinib. Alectinib was tested against crizotinib, and now lorlatinib was tested against crizotinib. The eligibility criteria are 3B, basically unresectable 3B, and stage 4. These were older categorization of the AJCC. So essentially all metastatic. No prior therapy, ECOG 0 to 2, asymptomatic treated or untreated brain mets are allowed. Most importantly, patients should have had measurable tumors. Now, the drug dosage was 100 milligram here, and crizotinib at the standard dose of 250 BD, stratified by presence of brain mets and ethnicity, no crossover permitted. PFS was the primary endpoint. Secondary endpoints included PFS by investigator, overall response rate, intracranial overall response rate, intracranial time to progression, and overall survival. Again, we were lucky enough to be one of the centers which did this study. We couldn't randomize many patients, but yes, we were one of the centers. Next slide. When we look at the characteristics, most patients are well balanced among both the arms. Interesting things for me, never smokers 54%, previous smokers 37%. So mostly fitting in the criteria. Almost all the patients were stage 4, 94% adenosquamous 4 and 3%, which is again something well known to us. A very few percentage of patients with previous therapy. Brain metastasis, a quarter, 26 and 27. So a quarter of patients did have brain metastasis at the baseline. This is an important point to remember. There are a lot of patients, a quarter of them, which is significant, had brain metastasis at baseline. Next slide. So we have certain data which is at 18 months and at 36 months. Now, the initial 18-month data, the PFS curves really speak for themselves. I mean, this is not something that we need to really debate. A wide separation goes on forever. We have hazard ratio of 0.28. Very well, good confidence intervals, a median PFS of 12 months, a percentage of 78% for lorlatinib, and crizotinib is only 39%. So almost a doubling of the PFS percentage at 12 months, 78 versus 39. Next slide. When you looked at the investigator-initiated PFS, again, remember this was the second, one of the secondary endpoints. Again, not evaluated versus 9.1 months. Hazard ratio 0.21. Again, 80 versus 35, which is pretty much the same. So a very significant improvement in the PFS, 80% PFS at 1 year, which is really huge. Next slide. When you looked at the subset analysis, really every subset did well. You had adenos here, you had smoking and current smoking, you had the brain metastasis everywhere. Lorlatinib had a very, very significant PFS advantage. Next slide. Now, the overall response rate, again, significantly better, 73 versus 58. When you looked at the median duration of response, crizotinib did 11 months, whereas this was not achieved in the lorlatinib arm. A significantly larger number of patients had an objective response rate in the lorlatinib arm. Next slide. So this was what the whole raison d'etre of lorlatinib is, that it works better for intracranial. So let's look at these responses. And here really, there's really no comparison. The intracranial objective response rate for lorlatinib is 66% versus 20% for crizotinib. Numbers are not huge, again 38 and 40, quarter of the patients. But looking at the median duration of response, again, very, very significantly better. Significant number of patients had CR, a small percentage had PR. When patients had measurable brain metastasis, again, 71% had a CR. And this is really quite amazing. You have a drug that gives you around 80% intracranial response rate in patients with measurable brain mets. I think that's pretty much something that speaks for itself. A drug that was designed to do this and really is doing what it is designed to do. Next slide. Now, the time to CNS progression, again, numbers are not too huge, but when you looked at those patients who had survival without CNS progression, huge numbers. In crizotinib, that number is 16.6 months, not reached in the lorlatinib arm. At 12 months, the number is 96% patients. So essentially, 96% of patients at 1 year did not have a progression in the CNS. And that's really what you're looking for in your ALK positive group of patients. Next slide. Again, looking at other factors like cumulative incidence of CNS and non-CNS progression, compared to lorlatinib, much higher for the crizotinib. If you look at CNS progression, it's 33% versus 2.8%. When you look at non-CNS, it's 44 versus 15.4. So cumulative incidence is significantly lower in the lorlatinib arm. Next slide. Overall survival. Now, the overall survival, the initial update of 18 months, when you saw, the survival was not really met. It was still evolving. The hazard ratio was 0.72, but pretty wide confidence intervals, and that's something we expect. The overall survival with crizotinib itself is close to 2 to 3 years, so you don't really expect this to come in the first follow-up. Next slide. Safety-wise, again, something that we would look at, serious AEs, 34 versus 27%. But again, we all know that what would you really want is the permanent discontinuation, and that is 7 versus 9%. It is similar to that in the previous studies and pretty much manageable. Temporary dose reductions, 49 to 47. By and large, again, these are trials. Remember that you see these kind of safety and AEs. In clinical practice, I think most of us are pretty comfortable with what we are seeing in terms of their side effect profiles. Next slide. When you're looking at all causality adverse events, again, the most important adverse events for lorlatinib, when you look at versus crizotinib, hypertriglyceridemia, edema, weight gain, neuropathy, and cognitive effects. We know these are more for lorlatinib, and that's what the study showed. Hypercholesterolemia and triglyceridemia significantly higher. Edema and weight gain also significantly higher. Crizotinib, on the other hand, significantly more diarrhea, fatigue, vision disorders, LFT disorders, and nausea and vomiting. Significantly higher for crizotinib. Again, not really a surprise. This is what we were expecting, and this is what the trial showed us. Next slide. QOL, the difference in QOL was better for lorlatinib as compared to crizotinib. And this again is something which is not too surprising given the kind of side effects that you see. Patients would not really be aware of their triglycerides and cholesterol, whereas they would definitely be aware of the fatigue, the nausea, and the vomiting. Next slide. So then came the 36-month follow-up, and I would be a little faster here because the same things were shown. When you looked at the PFS, now the PFS at 24 months and 36 months, still in the lorlatinib arm, it has not reached. So 3 years follow-up, 63% were still not having their PFS. And that's huge. So when you look at the number of events here, the PFS median in the crizotinib arm now has reached 9.3 months. At 24 months, it is 21%. At 36 months, it is 18%. But when you look at lorlatinib, it is 63%. And that's really quite huge. Significantly longer, confirmed overall response rate again is 77 versus 58%, so significantly higher. Next slide. Looking at the subgroup analysis, again, all subgroups really benefit, and these hazard ratios for PFS at least speak for themselves, 0.26, 0.27, and so on and so forth. Next slide. When you looked at patients, again, with the patients with CNS and without CNS meds, both the subgroups much better for the LORLA arm. In both the groups, that number has still not been reached. Hazard ratios 0.21 and 0.29. Median PFS 7.2 for Crizos, 11 here in without brain meds. Again, consistent with what we have seen with the original crizotinib papers. Next slide. Time to intracranial progression, much better for lorlatinib, significantly longer than with crizotinib. Next slide. When they looked at intracranial time to progression in those patients who had brain mets, again, over time, it is 73% at 3 years, which is very significant. So 7.3 months for crizotinib and not reached, and has a ratio of 0.1. So again, we are, I'm repeating the same kind of numbers, I'm repeating the same kind of figures, just to, again, re-emphasize the real effect of lorlatinib in the brain metastasis. Next slide. So this again looks at the time to progression, 30 months in crizotinib in patients without brain mets. Now, for me, the number really that matters is here. In those patients without baseline brain metastasis, 1 out of 112 patients had an intracranial progression. 1 out of 112 had intracranial progression, and really a drug that seems to work and do what it's supposed to do. Next slide. Next slide. So summary of adverse events, again, looking at the same numbers, your AEs leading to permanent discontinuation, 7 versus 9.9, which is along expected lines. Remember, the previous 18-month follow-up had 7 versus 9, it's 7.4 versus 9.9, and treatment-related dose reductions also 21 versus 14, not that significant, pretty much manageable. Next slide. Grade 3 AEs remaining the same. You have the edema, hypercholesterolemia, hypertriglyceridemia with weight gain. And on the crizotinib side, the nausea, vomiting, diarrhea, and vision disorder with LFT disorders. Next slide. So to summarize, when you look at all these PFS, which remained the primary endpoint, it was 0.28 and 0.27 at the 36-month follow-up. Response rate remains the same. And time to intracranial progression is significantly better for lorlatinib. Next slide. So for me, the key takeaways at 18 months of additional follow-up, continuing to show superior overall and intracranial efficacy compared to crizotinib. PFS remains longer, 3-year rate was 63.5%. Time to intracranial progression significantly longer. Benefits observed not only in patients with brain mets, but also those without brain mets. And again, this number, 1 out of 112 that exhibited evidence of IC progression. No long-term safety signals, and updated long-term also confirm the efficacy of lorlatinib over crizotinib. Next slide. So again, coming back to my panelists after a rather long discussion from my end. So again, if I can start with Dr. Poonam, madam. Madam, your thoughts of the data of this trial, and has it impacted your choice in the first-line treatment? I will not ask how likely is it, because this trial has come out a way back, though we are discussing it today. So how likely would that have, has it impacted your first-line setting?
So, yes, though we discussed about that one size does not fit all, but yet when I see an ALK positive patient presenting to me, lorlatinib is the first drug that comes to my mind, and I always would discuss that with the patient.
Okay. And what about your thoughts of the design, just head-to-head versus crizotinib? And is that good enough as a trial competitor, or would you have liked something else in the second in the comparator?
Yeah, of course, alectinib, if it was alectinib head to head, yes, it would have been better, but I think it's fine.
Okay. Dr. Prasad sir, your thoughts?
Yeah, since alectinib was earlier available to us, we were more familiar with that as a first line vis-a-vis the crizotinib situation. But now that with this compelling data in front of us, and maybe the costs also being similar, lorlatinib definitely comes into our mind. Yet to give it as a first line. Sometimes, as you said, we individualize the treatment and then you want to reserve it for the second line maybe, but then this data is quite compelling enough for us to think of it in first line.
Okay. Rakesh, your thoughts. The intracranial efficacy, and 1 out of 112 progressing in patients who did not have a brain met. That's quite amazing. Your thoughts on this other data?
If I can interrupt, Dr.
Yes, sir.
Vamsi,
Yes, sir.
the problem was my first experience with lorlatinib was not that
I think
that good,
that
especially.
is
Dr. Rakesh, just a second. I think Dr. Prasad is just,
yeah.
My first patient on lorlatinib had CNS mets and she didn't respond. So that's where you really can't have a huge impression to start with, I should say. Well,
Okay.
that's just a patient who took the compassionate lorlatinib. In our case, our radiotherapist people were more confident on lorlatinib than myself. And still, we had to go for radiotherapy in that particular patient. Ultimately, the patient succumbed. So these kind of things certainly play on our minds for quite some time, I would say. A young lady lost with an ALK positive disease. So that's how the situation is. But then after these kind of talks and all discussions, certainly we would always be wanting to try it again. Yeah.
I think it depends on your luck. Like my first patient on lorlatinib is still there on lorlatinib after 5 years. So it's just your luck, like you say. Dr.
Exactly.
Rakesh, your thoughts?
Yeah. So the point that you made that only one patient out of the 112 in the trial progressed with brain metastasis, those who did not have it upfront. So that actually is a very, very compelling point. It's an impressive trial data for sure. Real world practice might differ from trial, as Dr. Prasad was saying. That we have to agree. But having said that, whether I would want to use it for all comers in first line in ALK positive NSCLC, even if cost is not a barrier, I would still be little skeptical. Apologies to the organizers, but I still think we don't have a compelling enough data to say that lorlatinib is definitely the way to go for first line, because it is still, as you mentioned, it is compared with crizotinib, same like alectinib. If you had a comparison with alectinib, then obviously it would be, our job would have been easier. We have very, very good data across 3 data sets for alectinib, not like Crown trial, longer duration of follow-up. We have ALX, JLX, and Alicia, 3 multicentric randomized trials. We have a PFS of 35 months after the longest follow-up of almost 55, 56 months follow-up data. So a 36 months PFS across population, a 26 months PFS in patients with brain metastasis. So alectinib has a decent data. We all have to agree with that. And we don't have a compelling enough it's not like in EGFR scenario where we say that we can't reserve the best drug for later. We don't have a best drug as of now in first line ALK positive NSCLC setting. We have to pick and choose our patients. If you have an asymptomatic brain mets, yes, plus minus situation, you can go for alectinib or crizotinib. You don't have a brain metastasis, again, you can go for alectinib or lorlatinib. If you have a bulky brain metastasis where you want to avoid radiation, probably this is one scenario. I would be banking on lorlatinib to give me that magical intracranial response. And I have to confess, this is not a situation I have tried in, but this is one situation I have in mind where I would go to try lorlatinib upfront.
I think very well, good, very nice points made. And there's nothing wrong in playing the devil's advocate in any meeting. So I think I completely take your point, though. I think I only quibble with you that crizotinib still remains a first line in any choice. I think that's something which I don't really
Yes, that is my most commonly used drug, crizo versus ceritinib. Lorlatinib, alectinib, yeah. How many patients?
All of us have done that because of other reasons. But given a choice, I think I agree with you. Alectinib is still a good drug. it's something we would use, especially if, patients have very minor brain mets, like you said, or they have not had brain mets. You do get decent PFS and maybe use lorlatinib secondly. But any place with a brain met, possibly. I may be a bit biased because I'm presenting it today, but definitely I would still think lorlatinib is a good option in the first line. Completely agreeing your point that yes, alectinib also remains a good
Definitely.
Yes. Second, next slide, please. So again, when you look at guideline recommendations, now for me, this NCCN guideline, as usual, tries to cover everything and keep everyone happy. So if you discover it prior to first line therapy, you can use alectinib, brigatinib, lorlatinib as category 1 preferred. Other recommended is ceritinib. Useful in certain is crizotinib, and putting all as category 1. So it's a lot of how should I put it, tiptoeing around things and making a good response to good way to keep everyone happy. That's how NCCN gives. If it is discovered during first line, now this is very interesting. Even today, NCCN is okay that if you have discovered it during the treatment, I mean, you're given 2 cycles of chemo and you get this result, you can complete your planned therapy. And then you can either give maintenance chemo or interrupt it with these drugs. And I find it very fascinating. What if you had a PDL1 of 80% and you added immuno at that point? Would you continue immuno in a ALK inhibitor patient? And I think the answer is really no. So this part of it, I'm a little skeptical whether I would really agree with it. Dr. Rakesh, your thoughts? You start and you see ALK after even 1 or 2 cycles. Would you be comfortable continuing it, knowing what we do about everything now?
You continuing immunotherapy?
No. I said if you have a patient for whatever reason, you gave your first cycle, then second cycle, and 2 days after that, you get this ALK report. Would you be comfortable continuing chemo for 4 cycles?
Absolutely no. Absolutely no. I would definitely change at the first go.
Okay. Dr. Poonam, madam, your thoughts? I mean, this is NCCN has said you can do this, but how comfortable are we doing it? I mean,
so I would probably see how well the patient is responding. If the patient has done well, then I might continue for 4 cycles and then decide about changing.
Okay. Fair enough. So, Dr. Prasad, sir, your thoughts? Would you continue 4 or would you change? I would change. I side with Rakesh that give an oral and just be done with it.
Yes, there's certainly no doubt. I would change at the first opportunity. That's one. Second, as we see, patients also are nowadays well read or they come well prepared, and nobody wants chemotherapy unnecessarily. And so I would change at the first opportunity.
Right. Great. So I think that's one thing which we should all look at. Next slide, please. So this is the best we are going to get. Rakesh did speak about a head-to-head trial. Poonam madam said we don't have head-to-head trial. This is the best we are going to get. We are going to get either some form of a network meta-analysis. Now, this is the network meta-analysis. And again, for those who want to point out, I will point out there are authors from the Pfizer also in this group. So, with all due respect, that is also there. Next slide. This was presented in the IASLC. And what they showed is that compared to other treatments, when you did a network meta-analysis, again, we know the pluses and minuses of it. Look at all the different studies, including the encertinib, the brigatinib, alectinib, and all. What it showed is comparatively, lorlatinib seems to have better effect for PFS compared to all other treatments. This is what the study has said. Again, all of us will agree that there are caveats when you do a network meta-analysis, but between all of them, it seems that this seems to be an effective first line when compared to crizotinib and other next generation TKIs. Next slide. So this is, again, remember that most of these studies did not have a mature overall survival benefit. And again, comparing it to either alectinib, it was not showing anything. Brigatinib, again, it's all on the unity line, but there is no statistical difference, which seems to be there. But most of them were immature any which way. So I'm not sure whether this should be the one factor to decide whether to give or not to give. So we would like to have seen this OS advantage. I would have been very happy if I could, present today and say the overall survival is there. Possibly we may be seeing it later down the line. Next slide. So again, this is another network meta-analysis. This is comparing lorla, alectinib, and brigatinib in patients who are ALK inhibitor naive. And again, they said that in terms of PFS, results indicate that lorlatinib is the best treatment choice. Head-to-head trials, well, they're warranted, but whether we'll get them is a different issue. Next slide. So when you look at the network comparison as compared to among lorla and brigatinib, when you do the network plotting, again, a lot of statistical things here, which I'm not getting into the details of. So the results, when you saw ALK TKIs with head-to-head with crizotinib, it indicates that lorlatinib is the best first-line choice. It does have a PFS advantage over brigatinib and alectinib, with probability to reach the best PFS of 97%. So PFS is probably better for lorlatinib and alectinib. Again, remember, you are not comparing alectinib followed by lorlatinib as one of the arms. If you take that PFS1 and PFS2, would it be as good as lorlatinib alone? Not really addressed here. And again, remember what Dr. Rakesh has said, that should not be an option dismissed out of hand. You can still sequence with two good drugs also. Next slide. Again, subgroup analysis versus alectinib and brigatinib showing the benefit to be there. Next slide. So when they did a ranking of different TKIs, again, lorla, alectinib and all, again, showing that possibly the rank 1 should go to lorla, and then the other things come down the line. Next slide. So this network meta-analysis concluded that as compared to brigatinib and alectinib, it has better PFS. In terms of PFS, it seems to be the best choice. Again, remember, none of this has OS. So there was no significant difference among OS in these trials. Neither was there a big difference in the adverse event profile. Lorla, alectinib, and brigatinib have different adverse event profiles. So none of them can be said to the best. Next slide. So really coming to the experts again, starting for Dr. Prasad sir, your impressions of the adverse event data, and are they really what you see in clinical practice? Are you seeing these kind of adverse events? How difficult is it to manage lorla as a drug?
Not really. My limited experience with lorlatinib, I did not come across these side effects. Okay. Mainly, as we were discussing, that the hypercholesterolemia, hyperlipidemia, no, they were not a problem.
Okay. And what about the cognitive effect? This is something that people were a bit worried about when initially it came around, that you have cognitive effects and impairments and stuff like that. Have you seen that kind of thing in your practice?
No, not really.
Sir? No. Okay. Dr. Poonam Patil, madam, your thoughts on the experience of lorlatinib AEs and how difficult it is to manage them?
So I don't have too many patients, but in the small number, hypercholesterolemia and hyperlipidemia has been the most common AE, and hypertension in one, rash in one, and some kind of depressive symptoms in one patient were there.
Okay. Dr. Rakesh, your experience?
Yeah, limited, but I think it is a very easy drug to manage. The side effects are somewhat lab related only. Haven't had any reason to discontinue or decrease dose. I think it is pretty easy drug to manage.
No, I think that's something which we know about all ALK. They're easy to manage.
Across ALK. Across ALK.
Across ALK, I think they're easy to. I have had issues with ceritinib. The diarrhea is significant.
Probably the most difficult ALK TKI to manage is ceritinib.
Exactly. I agree with you. Even crizotinib had its share of nausea and vomiting. I didn't believe that an ALK could have it, but I had a patient who just refused to take crizotinib. Just refused because of the vomiting. It was a bit of an eye-opener for me. But again, handful of patients with lorla and handful with alectinib, really no big problem. Especially, patients who have done more than 3-4 years. They just come and take their tablets. That seems to be the trend for all of them. Yeah. And how significant is this lipid profile? Are we testing it? So in my 2 patients of lorla who are now crossed 4 years, I actually stopped testing it also. I should test it ideally, but it is getting tested once in 6 months when they turn up. So that's how it is. So I think that is one thing which we have known. Patients who tolerate drugs for a long time don't develop new side effects. After that, they seem to develop for a long time. Next slide. So again, common AE management, when you look at, we need to have lipid lowering drugs. We need to advise these patients that, look, this can happen and be aware of it. you need to be regularly monitoring and checking. So this is what we should do, and we should be doing, at least we all do it in the early stages. Later on, it does slip up a bit, as I have been very honest to accept, but this is something we should do. Next slide. So the guidelines are simple. I never remember them. I don't think any of us will remember them offhand. When it happens, we look at the guidelines, and these are pretty much well established. Next slide. For hyperlipidemia, yeah, these are the CNS effects. Now, CNS effects are something interesting. You can have cognitive function, mood, and speech. They can be mild, though again, there are patients who have had quite severe side effects. Now, the frequency of these side effects around 40%, with more than 12% experiencing more than one type. Baseline CNS meds are in a higher percentage of patients with CNS effects. The good thing is only 24 patients needed more than one dose modification, in which most patients had resolution of symptoms. A recurrence does occur, but a large proportion will be able to continue the medicines. And that's again something which is what we expect with most drugs. Next slide. So how do you modify? Again, there are very well established guidelines on how you're going to follow it. Next slide. So again, this comes to the next part of the question. Would you rebiopsy every ALK mutated patient? And would you want to do either a tissue or a liquid biopsy in these patients? So starting one by one, Dr. Rakesh.
So definitely yes, rebiopsy and if feasible, a tissue biopsy. These are RN fusions that we're talking about, and I'm not really comfortable with Indian labs with the liquid biopsy reporting fusion mutations. So probably if I'm able to do a garden, then probably fine. But by and large, I would definitely want to do a NGS again at progression, and preferably with a tissue biopsy.
Okay, perfect. Dr. Prasad, sir?
Yeah, I would prefer to do, though I individualize the situation, definitely it's on.
Okay, so Dr. Rakesh, quick question. You were saying you would want to do a liquid biopsy, which will cover the full spectrum like a garden, or would you want something that can focus on your ALK? Because remember, ALK mutations, you do not get, other bridge mutations like in EGFR. In EGFR, you have MET, you have RAS, you have other mutations developing, the BRAF and all. In ALK, it is usually an ALK resistant mutation which is happening. So you are locally basically looking at ALK again and again, right?
Yeah. So usually what happens in ALK is dependent upon what we have given in the earlier line. If you have given crizotinib, there is data to suggest that even EGFR mutation and MET amplifications are very well known. In second generation and third generation ALK inhibitors, the usual progression is with secondary ALK mutations. So almost 80 to 90% of times it is secondary ALK mutations, and very rarely you have MET or other PIK3 and all these coming up as resistance patterns. So I think suffice it to say that NGS is what I would do to pick both ALK changes as well as to not miss other changes as well. And I was saying that I would prefer a tissue biopsy over a liquid biopsy.
Fair enough. So that point is well taken. I agree with that. So next very important question, Dr. Poonam Patel, madam. So I think this is the crux of the whole discussion. Do you think we should sequence or use the most potent one upfront? I think that's the $1 million question that we have here.
Yes, $1 million question indeed. As I told you that I would tend to choose alectinib or lorlatinib upfront rather than starting with crizotinib or ceritinib.
Okay. Okay. Dr. Prasad, sir, your thoughts?
Yeah, certainly lorlatinib is trying to place itself like osimertinib in the EGFR situation, but then we need more data and the OS data and such other things. Till then, of course, you would prefer either alectinib or lorlatinib, depending on the situation, especially keeping the CNS meds in mind. Okay, so, no CNS meds. Probably I would take alectinib. Asymptomatic CNS meds, probably lorlatinib. That's how I would put it as.
So, Dr. Rakesh, I think you have a more nuanced opinion. You will say it depends on the patient, the condition, the presence and absence of brain mets, and so on.
Yes, yes, I've already made myself very clear at this.
I think all of us agree. I mean, if it is a simple solution, yes, we would look at it. I think one more important point that we have to make sure is what variant we are dealing with. If we have that data with us, are we dealing with a specific variant? And if it is variant 3, we know it really doesn't work. It's good to have an idea of what mutation we are dealing with as well. Sequencing wise, personally, my choice, I tend to go a bit like Rakesh. If the patient has elderly or has some comorbids, I'm not sure they can take a second line, I would possibly push my first foot forward, put LOLA up front. For CNS disease, I personally would prefer LOLA up front. PFS of 36 months not reached is quite an achievement. In other cases, possibly, yes, alectinib followed by lorlatinib could still remain a decent option. So next slide. So resistance pattern after TKI, again, we know that this is driven by mutations. You have secondary ALK domain mutations, particularly the G1202R. Next slide. And you do have this, which we present in most presentations on ALK, where you see that LOLA does not have much mutations where it doesn't work, except this initial BAF3 type, that is the I2193, 1293. Otherwise, it seems to work against most drugs. That seems to be a standard thing, which we all are aware of. Next slide. So again, different mechanisms are there, which you have ALK dependent, ALK independent. All of them are different for each of the individual ALK TKIs. Next slide. So overall, as you have more and more lines, the PFS does go down. Of course, PFS 1 plus 2 will work better. So potentially, the idea is the best PFS for lorlatinib is seen when you have the maximum, when you use it upfront. So I think that's, again, something we are aware of. And again, that's a matter of discussion. Next slide. So sequencing, one thing is it could potentially lead to more and more number of ALK resistance patterns. You could have so-called monster ALK mutations, and that possibly that is one other reason to push for using the best drug earlier. Next slide. So this is rapidly evolving. Again, a study that we keep talking about, the LX showing 34.8 months, your LORLA showing more than 36 months. So this is where we are. Next slide. So for me, key takeaways from the entire last 1 hour of discussion has been that in comparison to at least crizotinib, we have much longer PFS, higher overall and intracranial response rate, good QOL with better safety profile, and mostly the adverse events were asymptomatic and readily managed. When you use sequential ALK inhibitors, you will have more number of compound ALK resistance mutations. So whereas with lorlatinib, that's probably lesser. So all these seem to support the use of lorlatinib as an effective first-line therapy, though of course, all of us would agree that we need to individualize regarding our patients, individualize regarding the patient's condition. Next slide. So that really is the end of my talk. And really thanks to all the panelists. So any last comments from all of them, Dr. Prasad?
Yeah, you have summed it up quite nicely. In fact, I'm supposed to be doing the final closing session. I'll
leave it to that. I leave you to the summary. Dr. Patil, your last comments.
No, I think as lorlatinib came last amongst all the ALK, anti-ALK drugs, and alectinib came much earlier. So our experience with alectinib has been for the longest. But lorlatinib is indeed a good drug and easy to handle, relatively easy to handle.
Dr. Rakesh?
Yeah, one thing is we have so many options now. We consistently see 4 or 5 years in ALK positive patients. So that is very, very heartening. And I was just hoping that they will reduce the price further to 5-digit figure instead of 6-digit. So more and more patients will get on that drug. Okay, so I don't think we have any control over that, but at least we can peruse the science and at least appreciate. We can hope, yeah. Yeah. So over to Dr. Prasad, sir, for his final comment.
Thanks for the nice discussion. As always, Dr. Vamsi has put everything very succinctly. We are going home today with the data especially from the current 36 months data, showing that the best PFS is seen with lorlatinib. And so back tomorrow morning in our clinics, we would be thinking of lorlatinib more actively than alectinib, I would say. And the adverse events profile is also quite manageable. And so now I just learned while we were still in this meeting that the cost factors also for everyone to understand is similar to alectinib with the patient support program that the lorlatinib people are doing. And so with this, we are not wrong in selecting either of these drugs, but then lorlatinib, especially in a CNS disease, is the best. And if we find fault with, if we use it in first line, even without a CNS disease, and probably the monster mutations are also less with lorlatinib is one message that we are taking home today. But longer data will prove what mutations we are going to see in the future. And the NGS definitely being more and more available, we would be better placed to understand these mutations which are likely to be seen more and more in the future, and more options for treatment too. With that, I thank everybody for giving me this opportunity. Over
Thank
to
you,
Pfizer
sir.
people.
Yeah.
Over
Thank
to
you, sir.
Sanjay Prakash.
Thank you, sir. I wholeheartedly thank today's program director, Dr. SVSS Prasad, sir, for being the program, for accepting our invitation and taking the program through so successfully. I also thank Dr. Vamshi Krishna, sir, who has very wonderfully moderated the session. And I also thank the expert comments by Dr. Poonam Patil ma'am and also Dr. Rakesh Reddy, sir. So with your permission, can I please share the patient support program that we have in place for lorlatinib in the next 30 seconds or so?
Please do. Please do.
Sir, you did mention about the patient support program that we run, and Dr. Rakesh Reddy sir did mention about the access of the drug to various patients. We are more than committed to this cause. We are in fact working more towards making the drug more affordable. As far as today's Lorviqua care is concerned, the cost of the therapy to the patient per month in the initial day would be for the first month would be 2.5 lakhs. And the second month would be supported and so on. So that is the cost, that is the patient support program we have. And the effective cost of the therapy is 1,25,000 rupees as of today for lorlatinib. Yes, sir. And there is a patient counselor who takes the patient through the journey to make every documentation and everything hassle-free. So that's how we've been doing. And from Pfizer, I thank today's moderator for such very wonderfully moderating the session. What has been concluded is the fact that with so many options available to treat the first-line ALK mutated non-small cell lung cancer patients, the outcome of the CROWN trial and the discussion on the network meta-analysis, which Dr. Vamshi Krishna sir did mention, I'm sure for all the attending physicians today, which Dr. Prasad sir also mentioned in his concluding remarks, is the fact that the decision to make the first-line management would be quite easier in the office tomorrow, the clinic tomorrow. So with that, I thank the expert panel members who have contributed for today's virtual meeting. Thank you once again, and we look forward to learn from you all in the virtual meeting again. I also thank all the virtual healthcare professionals who have joined to this meeting, and also thank the HiDoc team for successfully helping conduct this meeting. Thank you, sir. Thank you, sirs.